So, could the practice of delayed antibiotic prescribing be part of the solution? This is sometimes called safety net prescribing in pediatric populations. And the basic notion is that when there's uncertainty about the etiology of a respiratory tract infection, it's advocated as a way to reduce unnecessary antibiotic use while maintaining patient satisfaction and empowerment and guarding against any rare bacterial complications. Now, this might work through either A, writing a prescription for an antibiotic, giving it to the patient, and instructing them not to redeem it unless they actually feel a lot worse or they fail to improve after a specified time period, often 3 to 7 days. Or it can also take the form of requiring that the patient return to the office to pick up the prescription or give them a post-dated prescription that couldn't be redeemed until some specified date in the future. Late antibiotic prescribing practices in the UK have actually been thought to be associated with a dramatic decrease in pediatric antibiotic use in the late 90s and early 2000s. But there's great variability with which this practice is used all around Europe and the United States, other North American countries. England by far uses it the most. And it's officially endorsed by UK and EU antimicrobial stewardship guidelines. It's not in any CDC guidelines per se, but is mentioned and sort of implicitly endorsed in some of their literature. So is delayed prescribing really representative of good antimicrobial stewardship? I mean, providers have been skeptical about this for a while, and perhaps with good reason. One recent conversation I had with an acquaintance went something like this. They said, so I had a really bad sinus infection a few years ago. I went to the doctor, they prescribed an antibiotic, but they told me to delay it, not fill it unless I didn't get better in 7 days. No, thanks. I filled it that night, started taking them, and felt better just a few days later. Um, so part of my research question, or the very crux of it, is is this sort of bad behavior common? Does this happen most of the time when we prescribe a delayed antibiotic prescription? Are people going to take it regardless of whether or not they feel better? Um, and part of what is concerning is that patients may take the antibiotic, start feeling better. We really don't know if it was the antibiotic or not that led to them feeling better. Possibly their viral illness was just starting to wane anyway. But in their mind, that association has been forged, making them more likely to advocate for wanting antibiotics the next time they're faced with a similar situation. So, as I alluded to in the previous slide, the main thrust of my question was to determine, as a provider, am I conducting an act of meaningful antibiotic stewardship when I use a delayed prescribing strategy for a respiratory tract infection? Is using a delayed strategy ultimately any different from giving an immediate prescription? So, are folks going to go out there and fill their delayed prescription as soon as they can, regardless of how they feel? Or will they actually delay and perhaps get better and not use their prescription? The previous version of the question was in plain English. This is the version in health research speak. It's called the PICO question. So we articulate the population, intervention, comparison group, and then the outcomes that we're measuring. So for my research, the PICO goes as follows. In all adult patients presenting as an outpatient with symptoms of acute, uncomplicated respiratory tract infection, what is the effect of a delayed antibiotic prescription compared to an immediate prescription on the rate at which patients ultimately consume an antibiotic for their respiratory symptoms? And I feel like I'm obligated to defend some choices I made here in developing this research question. First of all, I focused on adult patients because children are really a clinically distinct entity when it comes to respiratory tract infections. They have different diseases, different immune systems, possibly in more contagious environments and surroundings that are not able to advocate for themselves. Why did I choose uh, folks presenting as outpatients? Well, this is where most antibiotics are prescribed, and we also know that there's a very high level of unnecessary prescribing in this environment. Um, And lastly, I wanted to focus on uncomplicated respiratory tract infections because there's more equivocation in these cases as to whether we need antibiotics or not. If a patient presents with a suspected pneumonia, we're probably going to treat them empirically with an antibiotic. Or if they open up their mouth and there's a large peritonsillar abscess, probably going to need antibiotics as well. So mainly focusing on uncomplicated respiratory tract infections. So my goal was to perform a synthesis of the relevant recent research. I did this by looking in several databases, CINAHL, PubMed, and then also looking through reference lists of relevant studies. My date range was 2012 to 2019. Ideally, I would have been able to stick within the last 5 years, but a lack of studies within that time period forced me to push it back a little bit. Um, I'll let you hit pause and look at all my search terms if you'd like. I limited my research to peer-reviewed research, had to be original research, so not narrative reviews, say, of the literature. And they had to have both an immediate antibiotic group and a delayed antibiotic comparison group in the studies. And I included studies regardless of whether antibiotics were appropriate in each case because, again, this was not an examination of the research about whether providers are prescribing the right antibiotic. This is more of a study about what do humans do when they feel ill and have an antibiotic prescription that more or less they can use at their own discretion.